Hi everyone, this is Tim, your Block 2 lecture instructor, and today we're going to cover respiratory and the respiratory system. So before we begin, it was brought to my attention or suggested to me that I actually kind of use the book and also lecture, which I had done before, but then this time I think what I'm going to do is actually be a little more specific as far as um, doing the lecture slide by slide, but also incorporating certain pages, certain boxes, certain parts of each chapter, so that way you can kind of go back and study things that are a little more clear and things that I actually want you to know. I'm hoping that by now, especially for this portion of the semester, that you have actually read the respiratory and pulmonary chapters first, and you're using the voiceover as a kind of make things a little more clear. And then, like I said, as I mentioned things throughout the book, that you can kind of go back and read them, and then go to your study groups. I find that to be a little bit easier because, like I said before, I boil everything down from what you have read into what I find that's actually important. But at least you have an idea of what I'm actually talking about. So. All right, so here we begin. Let's see, for chapter 29, it starts on 543. Things that I actually picked out that I thought were actually pretty important. So let's see here. The first one is going to be 549, which is, let's see here, changes in respiratory system that are related to aging. I find that as patients get older, their lungs aren't as elastic, and airflow isn't as good, regardless if you're a smoker or whether or not you have emphysema or bronchitis or COPD or any other type of respiratory issue or no respiratory issue at all. Things just with age tend to slow down and not be as efficient. So another thing I wanted to point out was the bottom of the page of 49 is packs per year. So at this point, you're going to take the amount of packs per day and multiply it by the actual packs or multiply by the amount of years they've actually been smoking. And that tells you how many pack years. The reason why we ask this is because in the hospital we ask patients how long they've smoked and how much they smoked, and if they are currently still smoking, and it gives us a little better understanding of where they are as far as whether it be education and stopping smoking, or whether it be they have stopped and we can kind of at least tell them and educate them on how their lungs are doing now or what damage has actually been done. Some stuff is able to be treated. Some things are not. I don't necessarily think that any of the diseases we're learning in this chapter actually are curable. You're really just kind of treating the symptoms and making things better. So. Let's see here. What else do we got? Page 550, which was 29-2, which is the respiratory assessment. You have Gordon's functional health pattern. I think this is especially important because when you're assessing your patient, especially the ones that are being admitted into the hospital, you're able to kind of determine where they are in their breathing and their level of activity and what they're able to do and what they can't do. You'll find that patients with COPD in the first stages of COPD, they're able to still breathe comfortably and still do their ADLs and their just normal daily living things. But then as they progress and as long as the COPD gets worse, then they tend to not be able to do as much. So I think it's important as far as the admission assessment. I also think I put down here page 551, which is 29-2, the correlation of dyspnea classification and performance of ADL. So again, kind of know this box. You don't have to memorize the classes, but just understand that people who are in class 1 that have no real significant restrictions on their airflow don't necessarily have any restrictions on their ADLs. But then as you get down to class 5, they're entirely, restricted and both on breathing, but then that doesn't allow them to do a lot of physical things. So just be familiar with the classes and how that affects their ADLs. Let's see here. What else did I put? I also have down here too 550 page 550 on table 29-1 important aspects to assess in the respiratory system history. Again, I think this kind of goes back to the Gordon's functional health pattern as far as assessing them and kind of find out where they are and what they have been diagnosed with and how it really affects their life. So I think that between those 3 boxes on these 2 pages, I think that's probably pretty good for assessments and stuff. So let's see here, 555. I also thought was important. Let's see here, table 29-5 is the characteristics of adventitious breath sounds. Kind of review this. I know you guys learned this in block 1, but kind of go back to this a little bit, review this, and kind of be familiar with it, because I think it's important that, if you hear crackles, it kind of tells you what they possibly may be able to have, and as far as disease process, whereas with wheezing it's something else, and with the rhonchi it's something else. So just be aware of it. Someone comes in with COPD, what lung sounds, if it's exacerbated, should they really be having? And if they don't, I mean, that's okay, but it may actually be telling you something else. So just kind of said, be aware of the different characteristics and what the sounds are associated with what disease processes. Let's see here, 557. Again, here's another lab, box. Definitely know your labs. You might want to know red blood cells, definitely the H&Hs, which you should have already known by now. White blood cells based on infection. The differential white blood cells, know that because that's definitely a indication of what's going on with them. So excuse me, if neutrophils are actually elevated, this may indicate possible acute bacterial infection like pneumonia, COPD, or an inflammatory condition such as smoking. So when you look at your patient's labs and you find, hey, the basophils may be elevated, it may be telling you that the inflammation is coming, and this is kind of pretty indicative of like sinus infections and upper respiratory things. So so definitely know that. You should already know your ABGs, so kind of review that if you didn't quite get them the first time. And let's see here, I think that's it for this chapter as far as what I found important. I mean, you definitely read everything, but I find that those boxes I really want you to kind of know, and I definitely think, because as I've told you guys before, it's all about assessing interventions and finding out what the outcomes are. So so definitely go over those. And then, like I said, I'll sprinkle in some of the other chapters as we go. So all right, so back to the slides. Let's see here. So the first one is pleural effusion. This is abnormal fluid around the lung in the pleural space. Fluid accumulates in the spaces between the 2 layers. Normally the amount of fluid is roughly a few teaspoons, but with someone who's actually, has some sort of infection, whether it be pleural effusion or pleurisy itself, this is where the more fluid actually accumulates, and this is where they get sicker. And it's very much harder for them to breathe. The pleural space itself allows the lungs to move smoothly. So think of it as being a balloon that's slightly filled with, let's say, a few teaspoons of water. You can easily move that balloon against itself. But the more you increase the amount of water, the more it doesn't actually rub very well. Well, the more fluid that's in that space, the more it's rubbing up against things that are actually touching it. So the outer part of that pleural space is really rubbing on the inside of your rib cage, and that's pretty painful. So I think it's pleural effusion as being the accumulation of a lot more fluid that usually is there. Accumulation just doesn't happen, so usually it's some sort of disease process and usually some sort of infection. So, causes can be congestive heart failure, which is due to fluid accumulation. Another cause is pneumonia, which is inflammation. Again, it's a sort of disease process or infection. Liver disease is a fluid accumulation. Renal, as you guys know, is definitely a fluid accumulation because your kidneys aren't pulling off all the fluid. Pulmonary embolism, or PE, is usually an inflammation. And then autoimmune conditions such as, RA, or some of the other autoimmune things causes inflammation also. So think of fluid, anything that has to do with fluid accumulation, it's because it has nowhere else to go. With inflammation, those are usually because it's a disease or an infection related process. So for symptoms of pleural effusion, you get shortness of breath, you have chest pain, which is during the deep breathing. And again, I mentioned the pleurisy and the pleuritic pain. You can also have symptoms of a fever or a cough. The cough is probably due to the fact that if your patient can't deep breathe, then things will tend to settle. That's why we have patients do an incentive spirometer. If you take big deep breaths, you keep things open. Well, people with pleuritic pain or pleural effusion can't take deep breaths because it hurts. So if they can't do it, then they tend to get fluid buildup on the inside of their lungs, and that's what causes them to have a cough. And again, the fever is always indicative, or usually an indicative of infection. So. Diagnostic testings, they'll do a chest x-ray, they can do a CT scan, or they can also do an ultrasound. I think the best bet is probably going to be a CT scan. CT scans tend to show soft tissue images much better than the ultrasound or the chest x-ray. So I definitely think that'd probably be the better choice. So types of pleural effusion, there is uncomplicated. This is free from serious inflammation or infection, or could be no permanent lung problem. So it's more of a, think of it as more of like an acute versus chronic. So the uncomplicated is usually more of minor issues that can be easily fixed with no permanent problems at all. Whereas complicated is usually the fluid does have infection and it causes inflammation, and it's much more serious. Exudative is fluid has protein, blood, and infection. So it's gone from uncomplicated being less of a problem or a serious problem, whereas complicated is serious. And then the exudative is really fluid has truly built up and it's got proteins in its blood and its infection and it's it's nasty. So think of those three as being kind of a stage 1, 2, and 3 type thing. So for treatment, it could be simple as antibiotics, such as for pneumonia, or diuretics for CHF. Remember, pneumonia is more of a inflammatory process, so giving the antibiotics will cause the inflammation and the infection to go away. Whereas CHF is actually a fluid buildup, and diuretics is what will help pull that fluid off and actually be excreted by the kidneys. Another treatment option is a thoracentesis. This is actually, they remove large amounts of fluid off of that pleural space by taking a very large needle, a very large and long needle, and actually poking the pleural space and sucking the fluid out. So they can also do a tube thoracotomy, which is a chest tube. This will drain the pleural space, which you guys have actually seen in lab. I believe you actually saw the video, which I've actually posted on Canvas for you guys to watch if you need to. They can also do a pleural drain. I've actually had a few patients that have had this. These are the people who have repeated pleural effusions, and weekly they are literally building up, and the diuretics aren't helping, the antibiotics and anti-inflammatories. These things are not doing anything with the fluid, so the pleural space is filling up to the point where if they put a drain in, then it actually goes right into that pleural space. There's a port on the exterior part of their chest. Hook a needle up to it and it literally just sucks it out. And like I say, you're doing that either weekly, or some patients who have very bad pulmonary issues that are end stages of things tend to be need to be drained a lot more often than just once a week. So nursing diagnoses for pleural effusion, you have ineffective breathing pattern. We have ineffective, ineffective breathing pattern twice. We have impaired gas exchange, and we have activity intolerance and acute pain. So ineffective breathing pattern, again, if the pleural space is pretty full of fluid, it's not allowing you to take big deep breaths, and that becomes an issue. Like I said, you either can get pneumonia from not being able to deep breathe, things can settle, and then again, you start to get sick. The impaired gas exchange, again, if you can't take big deep breaths, then you're not efficiently being able to pull in air and allow it to circulate better than it was before. Activity intolerance, again, if you're not able to effectively breathe, and allow gas to exchange efficiently, then you're not able to tolerate a lot of activity. The acute pain, again, is due to more like the pleural C and the pain that's causing the pleural space to rub against the interior part of the thoracic cavity. So that's where the pain comes from. So as far as assessments, you don't remember how to do your assessment, and as far as finding interventions and what your outcomes would be expected for these 4 different nursing diagnoses, whether it be pain medication, whether it be incentive spirometers, whether it be breathing treatments, whether it be antibiotics. Those are interventions that you can do to make these things better. And again, the outcome is for them to be better. So for your assessment for a person with pleural effusion, there's tachypnea, there's crackles in both lung fields upon escalation, the use of accessory muscles, there's cyanosis based on not efficiently being able to exchange gas. Then you also have the orthopnea, you have pallor based on not being able to get enough oxygen. Restlessness, probably more from the anxiety. Nasal flaring because you're trying to consume as much air or oxygen as you possibly can. And lack of those things can cause confusion. And then the diaphoresis is more of the kind of a snowball effect of anxiety, not being able to breathe, not being able to tolerate the activity, and just pure anxiety and agitation. So, all right. So again, interventions, you can actually do a set of vitals to find out how well their oxygenation is, check out, see what their blood pressure and their pulse rate is. You're going to assess breath sounds, respiratory rate, their depth, and their actual rhythm. You're also going to elevate the head of the bed to make sure that they're able to sit upright. They're able to consume probably more air better that way. Perform deep breathing exercises. Things that you can also do is administer oxygen, teach the patient how to relax, minimize respiratory efforts, and to encourage rest. The less activity that they need to do, the more they're able to kind of retain what they are breathing and make it as efficient as possible. But I also think that keeping them nice and calm and relaxed, sitting straight up, giving a couple the nasal cannula to breathe a little bit better, I think is going to help as best as it possibly can. And I guess your assessments is really going to be determining what your interventions are going to be. All right, so real quick, see if there's anything in the book that I need to kind of fix or look over or mention real quick. Didn't see anything that I actually forgot in chapter 29. I did look and saw that on page 559 and 560 actually explains the thoracentesis. And I think that's important because as a med-surg nurse, I've actually seen several thoracentesis. They don't do them at the bedside. They actually do them down radiology. And again, it's usually a CT guided thoracentesis. But if you can at least know what you're looking at as far as, or at least knowing what the patient's going to go through, you can kind of better understand it and explain it to them. Because I've had patients that are kind of going, well, where am I going and what are they going to do? And if you don't know, then they really kind of get a little upset and they and a little anxious. But if you can kind of calm them down and talk to them and tell them exactly what it is and how it's going to be performed, it's going to hurt, but they definitely give some pain medication, some numbing agents, and I think they kind of relax a little bit more and feel more confident that you know what you're talking about. So I would definitely look into that. All right, so the next one is pulmonary embolism, or we know it as a PE. It's a collection of particulate matter that enters the venous circulatory system and lodges into the pulmonary vessels. Not quite sure exactly why the book had chose the specific words of particulate matter to describe pulmonary embolism, but usually it's a blood clot that has gone from either your legs or extremities or somewhere part of the body. It has lodged itself into the lungs. So this is usually blood clot from a VTE, which is a venous or vein thrombosis, or a DVT, which is a deep vein thrombosis. Again, they actually travel and then they usually get cut into the pulmonary vessels, and it causes hypoxia. Major factors that causes a PE: prolonged immobility, advanced age, surgery, a history of having blood clots before, or conditions that they increase the risk, like smoking or birth control pills, and also obesity. According to this, page 663, so let me go there real quick. 663, and it is box 34-1, which is the prevention. So let's see here. Yeah, I think it actually kind of goes over all these conditions that I mentioned before. So prolonged immobility. This could be anywhere from your patient laying in bed too long, going from bed to a chair and sitting in the chair all day long watching TV. It could be someone who's on a 12-hour flight from, England to here. It's the fact that you're not actually moving, and the movement itself allows your muscles to contract, and when your muscles contract, they also help blood move. So you sit in a chair for 12 hours. If blood is blood's still moving, it's just moving at a slower pace. And when you go down to capillaries, especially capillaries in your big toe, which is the furthest part from your heart, blood tends to, for lack of better terms, gets stuck, and that will cause a clot. So that will break off, and then, like I said, again, it gets caught into the pulmonary vessels. Advanced stage is another problem. Based on the older you are, things tend to be slower, things tend to pool, and that's where you actually get blood clots. Plus, there's also age-related disease processes like AFib or congestive heart failure. Peripheral vascular disease. There's a lot of things that as you get older, you tend to get disease processes, and that could also cause clots. Surgery is another one. Your body's trying to coagulate in areas that, whether it be surgical incisions, and sometimes those even break off. If you have a history of blood clots or pulmonary embolisms, that leads to possibility of having a greater risk further down the line. Let's see here. Obesity, again, the inability to move, or the lack of movement, or having some sort of sedentary lifestyle causes you to be an increased risk of having a PE. And again, look at 663 and chart 34-1. All right, so symptoms. It could be the sudden onset of shortness of breath or dyspnea. Another symptom will be sharp stabbing chest pain. Another symptom will be restlessness, the feeling of impending doom. I think that when I was in nursing school, there was a question on the test was, how do you know that a patient may be showing symptoms of a blood clot? And I think it was that that overwhelmingly desire that you're going to die, and I think it's because of the shortness of breath mixed with the increased heart rate and the anxiety that comes along with that. You also have hemoptysis. You may have tachypnea, crackles, a pleural friction rub, again, tachycardia, or decrease in arterial oxygen saturation. When you do ABGs, if you have a blood clot, obviously you're not able to breathe, or based on where the blood clot is not allowing that lung or that lobe to efficiently exchange air, which will then actually drop your oxygen saturation. According to this, 664, which is, let's see here, 34-2. So pulmonary embolisms and their key features, again, look at all that. I think actually most of the list that I have here on the PowerPoint is from this box. So, and let's see, what else we had, psych assessment. Let's go back to this real quick. All right, so I have a quick story. I had a patient a couple months ago that she had a femoral popliteal bypass graft. So there was a vein in her leg that had peripheral vascular disease, or the circulation just wasn't good. So they actually take another vein and they actually put it in its place. Well, you have an incision from pretty much your thigh all the way down to your ankle. And I had this lady for a couple of days, and she was kind of a heavy-set woman. Didn't really want to move around too much, but we were doing range of motion exercises. We had her on a blood thinner to make sure that the circulation continued, and that she didn't get a blood clot. And but she just, again, she just didn't really like to move very well. I had her for about 3 days in a row, and she was kind of a cranky lady, anyways, but also a little anxious, just in general. I gave a report to the night shift nurse, and told her how the day went, told her about keeping the pain medication up, current, and making sure that we can get behind on it. And for the most part, everything was okay. That night, I got a call around 9 o'clock at night, and the patient actually coded, and she died. And they believe that she had coded because she had a blood clot. And mostly from my perspective and the nurse's perspective, we think that she had thrown a blood clot was because she didn't want to get out of bed. Physical therapy wouldn't be able to get her out. She kept refusing them, kept refusing us. She kept refusing to get in a chair. She just wanted to live in the bed and didn't want to get out. But that lack of mobility, even on blood thinners, wasn't enough to keep her from actually forming some sort of clot. And she threw it, and it ended up in her lung. And then, like I said, she died. But what was interesting before that had happened is that she had told the nurse that she felt more anxious than normal. And this was an anxious person already. I mean, we had her for days on end, and we kind of knew how she was, her personality. But it wasn't just her being anxious, it was that severe anxiety of not, for whatever reason, she just couldn't explain why she felt so anxious. And then she ended up getting shortness of breath, and then she became very tacky, and then she actually sat up in bed. I mean, she always kind of sat, semi-Fowlers or high Fowlers, but this time she literally sat up, swung her legs around, and wanted to get up out of bed. This is someone who didn't actually want to do that. So um, it was the feeling of impending doom. She had some sort of feeling that she couldn't catch her breath and there was something wrong, and she just couldn't put her finger on it. And again, she just was more anxious than she was before. So anyways, they got her back in bed, and that's when she actually coded and died. So not that I want people to die, especially from lung, problems or pulmonary embolisms, but what is interesting is to be able to take what the book has actually said or what the symptoms should be and actually really match them up to what had actually happened. So it's very interesting. So, but definitely look at your features, your signs and symptoms, and kind of go from there. Psych assessment. So PE happens very suddenly. Patient is going to be anxious, and the patient is going to have that fear. So again, based on my story, she did present everything as the way it should have been for throwing a blood clot or PE and winding up in her lungs. So. All right, so labs and images, things that they're going to look into to prove that you actually have a blood clot or a pulmonary embolism. They'll do an ABG, which is going to be hyperventilation, which is respiratory alkalosis. You're going to have shunting, which is respiratory acidosis. And then you're also going to have a buildup of lactic acid, which is metabolic acidosis. So let me see if I can try to explain this. So with hyperventilation, obviously you're just taking big, deep, or you're actually taking very fast, short, shallow breaths, and this is what causes respiratory alkalosis. With the shunting, the blood clot has actually made it to some part of one side of the lungs, and it's causing air not to be able to come in, or oxygenation to be efficiently exchanged in that part, and it will cause respiratory acidosis. Um, with all of that, it will build up, and then it actually makes your lactic acid levels to be high, which causes metabolic acidosis. Do I want you to know these things? Not really, but I thought that was kind of important for you guys to at least have some sort of mention and kind of an idea of why, if you're doing ABGs, why this may happen. And again, you're looking at the patient, you're looking at their symptoms, you're looking at the disease itself and what is actually causing the problems, and that's when you start matching up lab work and everything else. You're really trying to piece everything together and make sense of it. Let's see here. For images, they'll do a chest x-ray, they'll do a CT scan, and they'll possibly do a TEE, which is a transesophageal echocardiogram. It's a Doppler ultrasound. Basically, go through your esophagus and look at the backside of your heart and into your lungs and find out if they can find that there is a blood clot. And I'm not sure there isn't. One thing that we tend to draw at that the hospital is there's lab work that they can actually draw, and that could tell you if those levels are high, whether or not a patient actually has a PE. But remind me in class, because off the top of my head, I think it's a, let's see here, a CTA is a radiology test, which can also determine a blood clot, but there's a D-dimer. A D-dimer will actually, if those are elevated, they tend to tell you whether or not your patient has a blood clot or a possible pulmonary embolism. So anyways, those are longitudinal images. So for management, for a non-surgical intervention, it's going to be oxygen therapy, vital signs, and drug therapy. I've had patients who have had blood clots and they actually need nothing because they're able to live with them and not need extra interventions. I had a guy about, I think it might have been a month ago, who had blood clots in his lungs, and it's because he traveled a lot, and he actually had one in his, I think it was his right lobe, and they put him on Levinox and Coumadin, and that's all he really needed. He was a walkie-talkie, self-sufficient. I think he was 61, but he didn't need oxygen. He didn't have an increased heart rate. He didn't have any anxiety. His blood pressure was fine, and he was perfectly a healthy person, other than having a PE. Last week, I actually had a guy that had a blood clot in his left arm, and a couple of them actually broke off and traveled to his lungs, but he needed oxygen. He had increased heart rate. He had a low O2 saturation, and we actually had him on Levinox and Coumadin to break up the blood clot that he did have and to keep other ones from forming. So some patients you'll need to do a lot of interventions, and some patients you may not need to do any. So again, look at your patient, their labs, their their vital signs. Look at them as a whole and try to piece it together, because again, you might need some things and you may not need everything else. Let's see here. I mentioned here in patients on anticoagulant therapy, page 668. And let's see here, box 34-6 and 34-7. So, best practice for patient safety and quality care, prevention of injury for a patient receiving anticoagulant and fibrolytic or antiplatelet therapy. So definitely know this. You're going to need to know what to do and how to prevent your patients from either bleeding to death or getting bruises, or interventions on how to change things so that way, I mean, when you're on blood thinners, you're not just taking something to thin your blood. You're not taking a little baby aspirin and things will go away and they'll become better. You're literally taking large amounts of medication that will thin your blood to get rid of clots, but that doesn't just start with the clot. It literally, brushing your teeth, your gums bleed, or you're shaving with a straight razor or a non-electrical razor, and you nick yourself, and those things don't stop bleeding, because obviously we want you to not, to not clot, and we want you to be able to break up clots, and that thins out your blood to the point where it happens all over. So definitely look at those boxes as far as preventing injuries and preventing bleeding. And then I think on page 669, a patient after pulmonary embolisms. Let's see here. Assess cardiovascular, assess. So yeah, definitely look at this box. There's a lot of assessments in here as far as what to look for and what to, because again, it's all about, assessing your patient and fixing what's wrong. So definitely look at those three boxes. And let's see here, page 665, 34-3. Oh, I already mentioned that. So the care of the patient with a pulmonary embolism. So definitely look at those boxes. I think they're very good information that's very bullet pointed and streamlined. So definitely learn those. All right. I take a little bit of a break. My throat is getting dry. Plus, I've sitting here in my office long enough and not moved, the lights go off. So anyways, I'm back. So the next one here is going to be COPD, which is chronic obstructive pulmonary disease. I think I'm actually in the chapter of 32. And I roughly started on roughly 612 is probably where I'm going to start for this portion of the PowerPoint stuff. So with COPD, we have asthma, which is a reversible airflow obstruction. This is for people who actually have some sort of reaction to something, and it causes inflammation. It doesn't allow them to breathe real well. We have chronic bronchitis, which is inflammation of the lining of the bronchial tubes. And we also have emphysema, which is the loss of the lung elasticity, and hyperinflation of the alveoli. So again, as you guys have learned in Block 1, that COPD is actually an umbrella for 3 different disease processes. So the COPD is pretty much a generic term for some sort of inflammation and not being able to allow air to move very well. So chronic dyspnea with the respiratory airflow limitation. Causes for COPD could be either airway inflammation, mucus plugging, narrowed airway lumina, or airway destruction itself. So again, when you think of COPD, think of about the patients who have some sort of inflammatory process going on that it does not allow the air to reach its destination very well or efficiently, and either it gets trapped or it just doesn't actually make it to where it needs to go. So diagnostic studies can be a chest x-ray, it could be a pulmonary function test. ABGs is more of like the labs to find out how well they are breathing and how efficient the exchange of air is or gas is exchanging. We have a DLCO2 test. We have a bronchogram. We have a lung scan at CBC, which obviously tells you whether or not they're, as far as more labs. And then they also have a sputum culture, and the sputum culture will actually tell you if they have some sort of infection going on. So what else do we have here? So priorities. Again, with COPD patients, you're going to maintain an airway patency. You're going to assist with measures to facilitate gas exchange. COPD is not reversible. It's not curable. It's, for the most part, it's really just a baseline for these patients. So you're going to assist them in trying to allow the gas exchange to be as efficient as it possibly can. You're going to enhance their nutritional intake. The more protein, the more calories they get, at least the better they can possibly live with this condition, and keeping other infections away and keeping some sort of healthy being instead of just living with COPD and just constantly or chronically being sick. You're also going to prevent complications. You're going to try to slow the progression of the condition down. Again, you're not going to cure it, but at least you can try to take steps to make it better. And whether that be, and I've told you stories before, patients, 89 years old, they have COPD, they can barely breathe, and they're at home puffing away on cigarettes like nothing. Well, 89 years old, they've smoked for, 50, 60 years, they're smoking one right after the other. And you know what? You may not be able to actually get them to stop smoking, but at least either cut back or try to do things to actually be a little bit better. And I know that's not the right direction to go in. But if you can get them to stop smoking, that's great. At least you're slowing the progression of COPD. You're trying to save whatever they do have left. But again, every disease process, and I've told you guys from renal to now, including diabetes, that everything is all about teaching your patient. And if they can understand their disease process and learn what to do to make something better and to take the interventions and the priorities and try to live as best as they possibly can, it keeps them out of the hospital. Most of these disease processes so far is always an exacerbation of something that they're not able to manage at home, and that's what brings them into the hospital. So if we can teach them how to stay out of the hospital by doing simple things, then that's going to be your best bet. So again, one of the priorities is really preventing complications, the exacerbations, the pneumonias and the infections and the pleurisy and all those things, so that way they don't have to come to the hospital and not be able to breathe. Provide information about disease process, prognosis, and treatment regimens. So again, it's all about the education. Nursing diagnoses can be ineffective airway clearance, impaired gas exchange, imbalanced nutrition, risk for infection, and knowledge deficit. And those actually are pretty, it sounds redundant or it sounds basic or it sounds like it's not complicated enough, but it's really that simple. And all you're trying to do is keep them breathing and taking what they have and being as efficient as possible. keep the gas exchange coming, and the nutrition is definitely going to help with that, keeping the infection away. And then, like I said, you're just trying to teach them as much as you possibly can within their realm of learning. So assessment and interventions, you're going to auscultate breath sounds, you're going to assess and monitor respirations, you're going to find out whether or not they're breathing too fast or too slow or too deep or not deep enough. Again, you're trying to make what they have as efficient as possible. No degree of shortness of breath. You're going to monitor their level of consciousness. I've talked to Block 4. They do their lab simulation in the afternoon, and they actually have a simulation with a patient who has COPD, and things that they're harping on in Block 4, and even in the real world, it's the level of consciousness. If you do not have enough airflow and you're not getting enough oxygen, you're going to start being lethargic and confused, and eventually, not getting enough oxygen anywhere, and that could lead to death. But the level of consciousness is the first indicator of telling you whether or not your patient's breathing efficiently and effectively. Now, I say that as a walking the room, I'm looking at the patient and I'm asking them questions, and someone who was alert and oriented is no longer alert and oriented. So that's one assessment. But if you're doing vitals and someone looks like they're fine, they're watching TV and answering all the appropriate questions, but they're O2 saturations down in the 80s, that's not necessarily great, but that's another assessment indicator of not having enough. So don't think of it as being level of consciousness being the only thing that tells you that it's low. It's just it's a one piece of the puzzle that tells you that it's low. Things that you can actually do is elevate the head of the bed and teach tripod positioning. You're going to limit environmental pollution. We at the hospital used to use talcum powder or baby powder for our patients that were bedbound and that were incontinent. We would actually, clean them up, we would dry them off, and then we'd put some baby powder down, and it helped as an absorbent barrier. The problem with that, though, is the patients who have asthma or COPD or respiratory issues were not breathing well with that. So an environmental pollutant could be the talcum powder, or it could be, living in Arizona, it could be the haboob. I mean, it could be anything, but if you can limit those triggers, then at least they're not having to worry about, some sort of exacerbation, or if you can't already breathe, you don't need to add more to that. You're going to encourage abdominal and pursed-lipped breathing. You're going to increase fluid intake to 3,000 milliliters a day. This is not only to keep them hydrated, but it's also to keep, the more hydrated they are, the more or the thinner their secretions are going to be. So those who, I know COPD is a dry cough, and it's not necessarily a mucus-producing disease process, but if they're going to get the secretions, especially in their lungs, then thinning them down is easier to cough up and cough out than something that's actually thick, and that's usually because of being dehydrated. You're going to monitor the ABGs, pulse ox, and chest x-ray. This actually tells you whether or not they're getting better or getting worse. You're going to evaluate the level of activity. Again, with people who can't breathe real well are able to do a lot of activities. And we're not talking about brushing your teeth. We're talking it's hard to go from the bedroom to the couch, or going from the couch to the mailbox, or even walking around the mall. Those are the activities that put a lot of strain, because the more you move, the more oxygen you need, and then that actually causes activity intolerance. You're going to evaluate sleep patterns. People who either have COPD or bronchitis or asthma or even sleep apnea, those people don't sleep really well, and they may be sleeping but not getting nice, deep, restful sleep. So you want to definitely evaluate that. And most of the people who have some sort of COPD disease process have to usually either sit in a reclining chair, like a lazy boy, or will actually lay in a bed with a lot of pillows propping them up so they're able to breathe a little bit better. You're also going to avoid extreme hot and cold foods. And in the simulation that I did yesterday with Block 4, and this is no fault of their own, but one thing that they didn't understand the concept is that when you're drinking something that's extremely cold, it's going down your esophagus and into your stomach, but it's also bypassing the lungs. So if you're going to cool off the esophagus and the stomach, then you're also cooling down the lungs. Well, extreme colds to the lungs is a vasoconstrictor, and if someone who already can't breathe is now being constricted, then they can't breathe any worse or any better. So patients that you have in the hospital that will ask for water or soda or juices or whatever, you usually don't want ice in them because of the fact that it takes their breath away and they can't breathe as efficiently as they could before. They already have hard times doing that. So, but they tend, excuse me, they tend to actually like to drink like the room temperatures or the warm broths and the warm stuff because it is a vasodilator and allows them to breathe a little bit better. So again, I mentioned before, education. So you're going to explain and reinforce individual disease processes. So, someone who has COPD, find out if it's COPD with emphysema or COPD with bronchitis or COPD as being an asthma problem, because you have to be able to take your individual patient with their individual problems and educate them on them and be able to explain their signs and symptoms and their problems. Giving generalizations, when patients find out that it's not necessarily pertaining to them, then eventually they just kind of stop listening to all the things you have to say. And that's just a general rule. You're also going to instruct and teach a patient about breathing exercises, coughing effectively, environmental pollutants, smoking cessation, discharge follow-up. Discharge follow-up is a very big thing, especially with patients that leave the hospital. We can give them all the education. They can say, yes, I understand it. But if they don't follow up with someone in 2 weeks or 3 weeks or a month to find out that things that we have fixed in the hospital are still okay, then they don't go anywhere. Eventually, 6 months to a year down the line, then they get sick all over again, and we find out that for the last year or 6 months, they just haven't been doing the things we told them. Follow-up is very important, so that way we know that, we have, fixed the exacerbation of their COPD. They're going home, they're on their regimen of whether it be breathing treatments or medications or antibiotics, and they've actually finished it, they've gotten better, and they're on the road to and not recovery as far as getting over COPD, but on the road to recovery of getting back to the baseline that they were at before. Educate them on their medications. They're either OCD about taking their medication on time every day because they know how it makes them feel so they can breathe, or they don't take the medications, they take them when they want to or when they can afford to or whenever they desire, and they just live with that stuff. So you have to be able to teach them and educate them that it's just not you can take it when you want to. It's you should be taking this so we can, again, prolong the progression of your disease, and sometimes medications will do that. So also educate them on oxygen requirements. Told the class in simulation yesterday, I had a father-in-law who died of lung cancer, and the last 6 months to a year of his life, he was literally taking SVN treatments or breathing treatments or his medications like every hour. I mean, he self-medicated, and he did it because he knew that the lung cancer was progressed to the point where he was going to, he knew he was going to die, but he did things because they made him breathe better. Well, with breathing treatments, you should only be doing it every 4 hours or so. Well, he was doing it every hour because that made him breathe better. His medication, sometimes they could afford it and sometimes he couldn't afford it. So he took his medications when he had them, or he would take them every other day because he was able to prolong that until the next time the check came. So you have to find out how your patient is and how educated are they and what their financial status is, and really kind of dive deep into what works for them and what can they do and how they can get there. Because it's not a matter of, if in a perfect world we could sit down and say, hey, here's a pill, you take this every day, and this is what's going to do it, and this is how it works, and buy and have a nice day, then that would be great. But some of these patients have a lot of issues or a lot of other social, psychosocial, family dynamics, socioeconomics. There's a million factors of what people are going through, and you really have to find out what that is so you can effectively teach them as much as you can. All right, so discharge goals. Let's see here, ventilation and oxygenation to meet self-care needs. Again, these patients go home, they're going to be at least hopefully walking around more than they were when they were laying in a bed for the last 3 days in the hospital. So you want to make sure that they were able to get enough ventilation, enough oxygenation to be able to do their ADLs. Nutritional intake meeting caloric needs, infection treated and prevented, disease process, prognosis, and therapeutic regimen to make sure it's understood. So again, discharge goals is really getting them to understand what they're taking, have them teach back to you what they're taking, and that they understand what they're taking and why they're taking it, their nutritional needs, make sure they're actually going home and they're cooking 3 good nutritious meals a day and not just one because, someone brought it, in preventing infections and making sure they understand what it is that caused them to get infection and how they can prevent them from happening again. The disease process of making sure they understand all this stuff. And it's hard, but, I told you guys the same thing about diabetes. If you don't understand it, how do you expect someone who has the disease to understand it? And the whole point is to actually get them to understand it, take their medication, do the interventions, make sure the outcomes are successful in keeping them out of the hospital. All right, so let's see here. I was trying to see if there was any pages that I wanted you to look at as far as boxes. Let's see here. COPD is in 611, bronchitis is in 612. I don't see anything that really sticks out at me too much. No, I think that's okay for right now. Well, I think I actually covered most of it, but 614, 615, 616, 17. There are some boxes, like one of them is the classification of COPD severity. You can look it over and kind of understand it, but I don't think that's necessarily something you need to memorize. On 619, there's the patient family education, preparing for self-management, the breathing, the pursed lip breathing. I mean, that's obviously definitely an intervention that you need to teach your patient so that we're able to effectively and efficiently breathe. Especially the box in the picture, it has the one at the bottom where there's a woman breathing in and out. And I was really surprised that other blocks hasn't learned this yet either, but when you have a patient who's actually low on oxygen and you put oxygen on them, whether it be through nasal cannula or a mask, you're actually having them breathe in through their nose and breathe out through their mouth. And one way that we learned it was to, sniff the flowers and then blow out the candles. So you're actually breathing in through your nose and out through your mouth. And that actually helps a lot, especially with COPD patients or patients who are very anxious. Breathe in through your nose and out through your mouth, because that kind of keeps everything nice and calm. And it's nice and relaxed and consistent and slow and purposeful. And that's probably the easiest way to describe that. Let's see here. What else can I tell you? Let's see here. Let's go back to lung cancer, which is on page 630. All right, so lung cancer. I didn't find these statistics in the book. I actually found them on I think it was the American Lung Association website. But lung cancer, both small cell and non-small cell, is the second most common cancer in both men and women. So 13% of all new cancers, and they're also 20% of all cancers and deaths. So more people die of lung cancer than of colon, breast, and prostate cancer combined. 430,000 people have been diagnosed with lung cancer at some point. That's pretty big statistics, especially with, and I think with like my grandparents' generation, they smoked because that was just the fashionable thing to do. In the 40s and 50s, and possibly maybe earlier than that, they smoked because that was what you did. In fact, I was even told stories of how nurses smoked at the nurses' station, and doctors would smoke assessing their patients, and in fact, they even had smoking rooms and non-smoking rooms in the hospitals. So that was definitely a time when people smoked not knowing what we actually know now. And those people now are in their 80s and 90s. So it's not a shock that lung cancer cases are so high. And I'm not shocked that those people are living with COPD, and I'm not shocked a lot about a lot of those things. I think what shocks me now more than anything else is the amount of people who still smoke. And then, of course, you have the e-cigarettes and all that other stuff. But my point, though, is that for lung cancer, yes, the statistics are high, but those people are now coming into their 70s, 80s, and 90s, and are on the verge, I'd say, on the verge of death. But they're getting up in their age, and that's where they're starting to get all these cases of lung cancers and stuff. So, all right, so lung cancer is lung cancer and breast cancer is breast cancer. So the reason why I put this here is that regardless of where the cancer starts, or regardless of where it actually ends, it's still diagnosed as cancer. So if you have lung cancer and it spreads to your kidneys, you still have lung cancer that metastasized to your kidneys, not lung cancer and kidney cancer. Or renal cancer, or you didn't have lung cancer that spread to your breast and have breast cancer. You actually have lung cancer that has metastasized to your breast. So the reason why I say this is because you will, if you work oncology, or if you actually take care of patients who have lung cancer that has metastasized, you now are going to be taking care of two different issues, the lungs themselves and wherever else that has actually traveled. So there's different types of cancers that grow differently and are treated differently. So there are different types of tumors. There's benign and there's malignant. So for treatment of cancers can be surgery. It could be radiofrequency ablation. It could be radiation therapy. It could be chemotherapy. It could be targeted therapies, and it could be immunotherapies. I recently found out that brother-in-law has colon cancer that has now metastasized to his lymph nodes. And what he was doing, or is actually still doing, is he's doing chemotherapy, but recently they actually added radiation therapy to it. So the chemotherapy is a medication that you give intravenously or through some either PIC or a port, and you're on it for, I think it's either every other day or a couple times a week, and he does that for like 6 weeks. He went through a round of that, and then they actually end up just recently adding the radiation therapy, and I think he goes to that a couple days a week too. But essentially what it's doing is it's killing off everything that he has, whether it be good cells, bad cells, it doesn't matter. He's just trying to, the goal is to kill off all the tumor cells, and that just happens to take good stuff with it. Whereas targeted therapies are really more specific, either chemotherapies that are going directly to a specific cancer cell, or there's also radiation therapy that is specifically narrowed in onto one specific body part, and then actually will kill the cancer cells. So there's the different treatment types. You have a cancer team. You have a thoracic surgeon that actually treats the diseases of the lungs and the chest with surgery. You have a radiation oncologist, which treats cancer with radiation therapy. You have a medical oncologist, which treats cancers with medicines, such as chemotherapy. And then you have a pulmonologist, which is a doctor who specializes in diseases of the lungs. Floating in the flow pool, I tend to go out to oncology, or I'll tend to do the telemetry floor, and I'll see these different doctors, and it's not a really big deal, but it's nice to be able to know what each one of their roles are, because that kind of helps determine where your patient is in their disease process, and whether or not they need certain doctors to treat certain things, or it may just be as simple as COPD exacerbation, and the patient just needs a pulmonologist. Or again, patients who have developed some sort of lung cancer or oncological problem will tend to need some more help. So for cancer patients, especially lung cancer, you're going to do a health history. You're going to do what they call lung cancer screening. You're going to determine their age and find out if they actually fit into that 55 or 70-year-old time period. Have at least 30-pack year smoking history, and whether or not they're actually still smoking or have stopped smoking in the past 15 years. And then I put in here, don't forget the secondhand smokers. I might have actually told you this story before, but I had a great-grandfather who loved to smoke cigars, and he smoked cigars like like one after the other. And he lived in a very small house with a very small living room, and my sister and I would actually be in the living room, and he would just be puffing away on his cigars. And when I say that he smoked, I mean literally the living room was full of smoke. And my sister and I would actually run into the living room. We would take big, huge, deep breaths, and then we'd run out of the living room and into the kitchen, and then we'd exhale, and we'd be able to actually blow out the smoke. My sister and I think we were like 5 and 6 at the time. We just thought that was the funniest thing. But it's true. I mean, that's if we live there, then we would be exposed to a lot more secondhand smoke. But people don't realize that, smoking around their kids or smoking in cars with the windows rolled up and their babies in the back seat, and that's not something they actually think about, or maybe they do. I don't know. But secondhand smokers can get lung cancer just as easily as people who actually do smoke. So we have to kind of keep that in mind. All right, so warning signs of lung cancer are hoarseness, change in respiratory pattern, persistent cough, blood-streaked sputum, rust-colored or purulent sputum, chest pain or chest tightness, shoulder, arm, and chest wall pain, recurring episodes of pleural effusion, pneumonia, or bronchitis, shortness of breath, such as dyspnea, wheezing, or clubbing of the fingers. So basically, be familiar with the signs and symptoms. And I think that lung cancer symptoms tend to already present themselves like COPD or bronchitis or like asthma, and then they just progressively get worse to the point where they can't be maintained, and then they start looking at them. I think most people who actually have COPD probably get a chest x-ray once a year, just to make sure that if they were a smoker or had some sort of lung illness that developed into COPD, they tend to look at them a little more closely, making sure that things don't progressively get worse. And they're probably screening for cancer also. So for a physical assessment, you're looking at fevers, chills, cough, and sputum. With lung cancer patients, especially with some sort of nodule or something in the lung that causes a lot of infection, you tend to cough up a lot of stuff, a lot of sputum. So you're going to look at the quality and the quantity of it. You're looking for blood tinged, and you're looking for purulent and copious amounts of it. People tend, especially nursing students, tend to use the ineffective airway clearance. And this is a perfect example of that. There's too much of it, it's too thick, and it can't come up and can't come out. So for the breathing, you're looking at labored, painful breathing. You're looking at shallow and rapid breathing, abnormal retractions, use of accessory muscles, flared nares and stridor. You're looking at asymmetric diaphragmatic movements, and dyspnea and wheezing. And I mean, I hate to dumb it down or make it sound simple, but it's really just as simple as that. If you can't breathe and if you have lung cancer and you can't breathe because of nodules, including a certain area or all of it, you're going to have the inability to actually breathe well, breathe efficiently. It's going to be hurtful. You can't cough things up because you can't take the deep breaths, and you're going to try to use whatever you can to breathe as well and as efficiently as possible. So the flared nares and the stridor, the flared nares is because you're trying to use what you have to consume more oxygen, and that's what your nares are there for. So the dyspnea and the wheezing, that's really the shortness of breath, and the wheezing is because you're just not able to, cough up and out all of the, purulent and copious amounts of sputum. So. All right, so assessment of the lungs with a mass. You'll hear dull sounds over the mass itself. You'll hear wheezing based on the amount of sputum that's actually around that area. You'll have a decreased or absent breath sound based on if you, let's see here, see if this actually works. So let's see here, yeah, it didn't work. Okay, it didn't work. I was trying to use my little stylus to see if I could draw a picture, and it didn't. All right, so let's see here, the assessment of the lungs of a mass. Let's say you're actually looking at your patient that has a mass on the right side of their lungs. It's on the right lung, it's the middle lobe. It is, let's say, golf ball size. Wherever that is stuck or positioned or implanted or whatever you want to call it, wherever that mass is, anything below that will not have air exchange or oxygen exchange. So that's where you probably will get the absent breath sound, or that will actually be decreased. And then with lung cancers, especially, well, let's take that same spot with the golf ball size mass. If it's actually pushing on the lung, which is actually pushing on the pleuratic space, you will get a pleural friction rub. So it's actually pushing everything out towards the thoracic cavity. So hope that makes sense. All right, so for assessment, ask your patient about shortness of breath with activity, shortness of breath without activity, and shortness of breath with all active daily living situations. Again, what you're trying to do is try to make what they do have as good as possible, as efficient as possible, so they can still carry on their normal active daily living things and keeping them out of the hospital. So non-pulmonary for lung cancer, they have heart sounds, maybe muffled, dysrhythmias due to hypoxia. They might have cyanosis, which is usually the blue lack of oxygen in the blue, ring around the lips and the fingers. You'll have fatigue because obviously you're not getting enough oxygen, so you feel very tired. You have weight loss because you can't, a lot of people can't eat and breathe at the same time, and people who have COPD, that's really hard for them to eat and breathe. So a lot of times they just lose their appetite and don't actually eat very well, and they become very anorexic and lose a lot of weight. The dysphagia, again, is the inability to actually be able to eat and swallow and breathe all at the same time. And sometimes it actually causes nausea and vomiting. And I think a lot of it has to do with just the gasping for air and swallowing and stuff that tends to kind of make you feel sick. So psychological due to lung cancer. And I think you probably can even apply these things to any respiratory or pulmonary disease process. You have fear, you have anxiety, and those are due to the fact that whether it be the fear of death, whether it be anxious over not being able to breathe, those two things are probably the first physiological things you probably can see face to face, and it's a psychological issue. Your patients will tend to actually start to feel guilty and shame, and the reason why is because those who are still married or have young kids or used to be very active no longer can be as active as they were before. I work with a woman who is a nurse, and she travels from Buffalo, New York to Phoenix, and I work with her at Scottsdale. And she comes every winter, and her husband, and they're kind of like snowbirds, but she still works. And she's a really nice lady, and she's probably, I'd probably say a young, maybe mid 50s to late 50s, maybe early 60s. But she's still active and still, physically able to do things. And, I think you're as old as you feel, and she feels good. So I think she's mentally still young. But her husband has severe COPD, and he never took care of himself, and he never took care of his disease process. And she had told me one day we were talking, and she had said that she is living with someone who is very ill. And there's a difference between being ill and taking care of a loved one, and actually living with someone who is ill because they never took care of themselves when you begged them to take care of themselves, and now you're having to take care of them because they can't take care of themselves. And so she felt very guilty because of the fact that she wasn't able to do a lot of things, and she really had to take care of him, and she wanted to, but she also resented a lot of him because he just didn't, take care of his disease. I think he has COPD very, very badly. So anyways, she wasn't able to do a lot of things with him, or they weren't able to do a lot of things as a couple, and he finally passed away about a year or so ago. And not that she wanted him dead, but she actually had a lot of relief by not having to take care of someone all the time and putting her life on hold. And it wasn't a matter of her not being able to live her life or whatever, but it was just that, like I said, it was the resentment of trying to take care of someone that you love very much that wouldn't take care of themselves. And here you're young, and these are things that you could do. So now that he's gone, it's been about a year or so, she seems happier in the sense that now she's able to be with the grandkids and take trips and do things that she always wanted to do. So a lot of patients who have COPD or illnesses or lung cancer that doesn't allow them to keep up with their loved ones, there's a lot of guilt and a lot of shame in that. So But again, I put in this in here too to be, not be judgmental, because we tend to kind of walk into rooms and like, oh my gosh, you're still a smoker and you have COPD. We're like, what the hell's wrong with you? But you can't be that way. You can't judge them. You really just kind of be able to treat them, give them the education, try to be as understanding as you possibly can. I put this in red. I want you to know the stages of grief, because especially with lung cancers, and I know that you guys had went over anemias and cancers in the lecture before this one, but know your stages of grief, because it tells you where your patient is and whether or not they're able to either accept what you're telling them or teaching them or educating them, or try to get them, try to figure out where you need to get them, and kind of go from there. So you have to really look at your whole patient and treat them, and we try to do this in block one. Look at your patient holistically, whether it be psychosocial or socioeconomic, or like I say, you're really just kind of looking at where they are, where they came from, and where their goal is to go. So, but definitely know these psychological issues and what to do about them. So for diagnostics, they have cytology, which is a sputum sample, and it lets you know whether or not the infection is cancerous. The thoracentesis, which I actually wrote down, is on page 559 and 560, and I think I already told you about that. That goes over the thoracentesis. They can also do an X-ray, CT scan, a PET scan, which actually detects cancerous cells. They have a pulmonary function test, and then they have the ABGs. So. All right, so interventions for cure. So for non-surgical interventions for lung cancer, you have chemotherapy, targeted therapy, radiation therapy, and photodynamic therapy. And then you also have surgical therapy, which is going to be the lobectomy and the pneumoectomy, which is either removing the lung itself or just removing one of the lobes of the lungs. So for non-surgical, side effects are the nausea, the vomiting, hair loss, immunosuppression, anemia, thrombocytopenia, and mouth sores. So I definitely want you guys to know, based on the side effects, because that's your assessment, right? You walk into a room, your patient has lung cancer, they're on chemotherapy, and your assessment is nausea and vomiting. So your intervention is going to give the nausea medication, and then you're going to evaluate that. Did it actually happen? Patients that have cancer that are on chemotherapy or radiation tend not to be hungry or tend to be nauseous and vomiting a lot and aren't able to eat real well. So, again, you're assessing the weight loss. You assess that they're nauseous and vomiting. You're going to give them nausea medication so that way they're able to actually eat, and then hopefully the expected outcome is to gain the weight. So think about these things as far as side effects and what your assessment and your interventions and your outcomes are going to be. Hair loss, I know that usually, at least my brother-in-law told me that last week, the week before, that he, hasn't lost his hair yet, but he knows as soon as radiation starts, he'll actually start to lose it. And he's met with people who also have cancer, and they just found that, shaving your head was just the easiest thing to do instead of wait for it to all fall out. So, but you got the immunosuppression, so you have to really watch about whether or not they're around people who are sick, or teach them about wearing masks when they're in public, and making sure that they, wash their fruit and don't eat fresh vegetables, and just, again, it's a lot of teaching. Then we got the anemia, thrombocytopenia, which is the blood clotting disorder, and then we have mouth sores. So they have the biotine, and they have the miracle mouthwashes, and things that will actually help with those mouth sores, whether it be painful or just kind of numbing agents. So. All right, so let's see here for pneumothorax. Let's see here. I had wrote down. Pneumothorax is 683 and 684. All right, so let's see here, 683 and 684. I don't think anything's of particular. Nothing, no box really sticks out, but understand what pneumothorax and hemothorax, even tension pneumothorax actually means. With the pneumothorax, it's any chest injury resulting in air entering the pleural space. It's the same space as the pleural effusion, so it's that pleuritic space. Essentially, it's a collapsed lung. So air goes in, it actually, based on gravity, pushes the lung to one side, and it forces it to not be able to inflate. Causes can be trauma, medical procedures such as thoracentesis, perfect example. Excuse me, your patient will have some fluid built up in the thoracic cavity, or even a see here, we have the thoracentesis and the pleural centesis. So needle goes in to actually, pull the fluid off. And if they just don't go in the right spot, or they'll go a little bit too deep, or a little too far up, or a little bit too far down, and they actually nick the lung, that will cause an actual hole, and that hole itself will allow air to go in. So that's the medical procedure. Sometimes you put in PICC lines or ports or things that have to actually do with something that's under the skin, around the pleural space or around the lung area, and sometimes they go a little too deep and they puncture a lung, and that's what causes it. So the solution is going to be obviously a chest tube. The chest tube is designed to be able to pull the air out or keep it out so that way the lung can actually inflate. The hemothorax is the same as a pneumothorax, but with blood. The cause is usually from blunt force. The size can be little or big, and the amount of blood loss can be small or large. So again, it's just like a pneumothorax, but it's actually blood. So whether or not you hit an artery or a vein, or when you guys saw the video of the chest tube placement, if you happen to nick something, especially a blood vessel, the blood itself will actually pull into that cavity, and it pushes on the lung itself. So the solution is going to be suction and chest tube, or chest tube and suction. So I put this on there because if you, let's say, someone gets stabbed with, I don't know, a metal rod, and it actually punctures a artery and it goes into that pleural space, it's going to bleed internally and externally. So at that point, you're going to use suction to be able to suction out the blood, and to be able to place the chest tube. Or you're going to place the chest tube, and that chest tube itself is going to suction, and it's going to suction out the blood. So that's why I put that in there. So it really works both ways. All right, so now we're going to cover the meds, but before we do that, let me make sure that I have all the pages and things that I wanted you guys to cover, so that we don't have to go back and read every single page in the entire book. All right, so let's see here. One thing that I wanted you to cover was chapter 34, 663, and I think I actually mentioned these boxes, but I wanted to make sure that I didn't forget something. So we have 663, 34-1, which is the prevention of pulmonary embolism. I know I talked extensively about that in the PowerPoint, but I also want you to kind of, I like this little box. So know the box for that. 664, which is 34-2, it's the key features of a pulmonary embolism. I think I mentioned that. I mentioned the care of a patient with a pulmonary embolism. And then the drug therapy, which is on 666, and which is 34-4, common examples of drug therapy. I don't think this is necessarily part of the syllabus, but I at least want you to be familiar with these drugs, because you're definitely going to get them in the later blocks, but in the same sense too. I hate to just say things that everything's fair game, but I think if you just understand the concept of the difference between heparin and what it does, and what warfarin and Coumadin does, the difference between a PTT and a PT and INR, knowing what vitamin K does and alteplase and stuff. So again, you don't necessarily have to memorize them, but just be familiar with them. And of course, on page 667, there's actually the labs, and kind of know what those are and what the actual parameters are. Because again, you're going to definitely know those as you become a nurse, but also the more you're familiar with them, the more things will just make sense as far as, again, assessing interventions and outcomes. Let's see here. Then I'm on 668, which is the prevention of patients who are on blood thinners, between 34-6, 34-7, and 34-8. Definitely know those, or at least familiar with them. And it's all about prevention, and especially people on blood thinners, which is following the pulmonary embolism thing. So this here, I took care of that. And let's see here, chapter 33, there's a little bit something that I liked in there, which was starting on 645. All right, 645. And I think that the reason why I brought this up is because for right now when I'm doing this PowerPoint and voiceover, it's actually flu season. And for half of us, we got sick last week, which was a week prior to the flu shot, so it didn't do us any good. So anyways, but what I would like you for you to know is, especially with what we're talking about as far as respiratory and lung issues and disease processes, the flu is a really big thing, and this really could kill someone who already doesn't have an immune system or already has respiratory issues. So definitely kind of look over the seasonal flu, understand that concept. Tamiflu, which is a big thing right now, because half the doctors in the hospital I work for, half of them believe that Tamiflu works, and half of them don't believe that Tamiflu works. So kind of just be familiar with it and what it does. And let's see here, what else did I have? I had 647, which was 33-2, risk factors for pneumonia. So be familiar with that. 648 was preventing pneumonia and preventing, just preventing pneumonia. The ventilator-associated pneumonia, you can be familiar with it, but until you get to block 4, you're never going to actually understand it or need to know it. So, and then I have on 650, 33-3. Let's see here, pathophysiology of common clinical manifestations of pneumonia. So definitely know that. And so let's see here, I covered all of that. And I think that is it so far. And then I will then cover chapter 30 and 32. There's a couple things I wanted to point out in there. So, all right, so back to the PowerPoint. So the medications you're going to be learning for this module, there's only a few of them, besides the blood clot or the blood thinners that I mentioned, which you actually I think need to know for the cardiac portion of this block. So it won't hurt to start noting, memorizing them and understanding them now. All right, so the first one is going to be Benadryl, which is diphenhydramine hydrochloride, which we just call Benadryl. It reduces the effects of sneezing, itching, runny nose, and watery eyes. It actually is an antihistamine. So the reason why I bring this up is because I think this is important to know for patients who have asthma, bronchitis, COPD, or lung-related disease processes, because if you're able to dry up secretions, then things don't necessarily drain from your head and your sinuses into your chest, and that causes more inflammation and more aggravation and more infection. So Benadryl definitely helps as far as drying things up and keeping things nice and clear. Side effects of Benadryl are induced sleep. I know that there's several nurses and probably half of you guys are taking Benadryl to help you sleep at night because it will make you very drowsy. For me personally, I've taken Benadryl and it keeps me wide awake, so it doesn't do anything for me. But it will induce sleep. It's dizziness and causes drowsiness. It will cause a dry mouth because, again, it's trying to dry everything up. It will cause a dry nose and dry eyes. Usually it's in 25 milligram or 50 milligram form, and usually you'll take it every 6 to 8 hours as you need it. You can take it by mouth. We also give it IV, and usually people like it IV because it tends to give you a more euphoric feeling. But in the everyday over-the-counter world, usually it's PO, and it's 25 milligrams to 50 milligrams. And the next one's albuterol. This is a bronchodilator. It's a long-term control, so it's not for those who, oh my gosh, I can't breathe and I need something right now. It is for those who will take it usually, I think it's either twice a day or at least once a day, and it's more of a, you take it every day and it keeps you dilated and allows you to breathe better. So it is a long-term control. It binds to the beta-2 adrenergic, which is relaxing smooth muscle. Because again, with COPD, whether it be asthma, bronchitis, or emphysema, it actually, those disease processes cause inflammation, and with albuterol, it actually decreases that inflammation and relaxes the muscles and allows you to breathe a lot better and deeper. Side effects are nervousness, restlessness, tremors, hyperglycemia, and hypokalemia. It also may cause a little tachycardia. It is inhalation. It's 2 puffs, and it usually lasts 4 to 6 hours. The next one is Atrovent. This is a bronchodilator with systemic anticholinergic effects. Side effects include dizziness, headache, nervousness, and tachycardia. Inhalation is usually 2 puffs 4 times a day. and do not exceed 12 doses in a 24-hour period. The reason why I mention this is just because, as I said before, there are people who self-medicate at home, and they'll take 1 dose, and if it makes them feel good, then 2 doses makes them feel better. So people tend to either overdo it, to take too much of it, or do what they can to make themselves feel better. Administer the adrenergic bronchodilator first, and then the aprotopium. So the idea is to actually administer the bronchodilator. So you're going to administer albuterol first and then Atrovent. And you wait 5 minutes in between the two, and it makes them just work more efficiently. All right, so Pulmicort is a corticosteroid in maintenance treatment of asthma. It's an anti-inflammatory. Inhalation is usually twice a day, and the onset is about 24 hours, and the duration is usually 1 to 4 weeks. So you will first take it, and it may not necessarily do the trick. The second one may not do the trick, but usually the third and fourth one will start to work, and then you just keep yourself on a maintenance dose. Side effects include headaches, agitation, depression, insomnia, and restlessness. Going to check adrenal function test to make sure, because it is a corticosteroid. And with this, you know that people who are diabetics tend to have higher blood sugars because of steroids. You're going to use the bronchodilator first, and then you're going to rinse your mouth with water afterwards to prevent thrush. That's it for these so far. Let's see here. Let me add a couple things. Let's go with chapter 32, and it's page 604. All right, so page 604, 32-3, key features. Let's see here, the step system for medication use and asthma control. So, definitely learn this. You're definitely going to need it. And let's see here. Asthma control, page 607 and 608. All right, so let's see here. Here is the pages for your bronchodilators, your long-acting beta-2s, your cholinergic antagonists, corticosteroids. Yes, definitely know those. So that's on page 607 and 608. And then let's see here, 32-8 is going to be on page 609, which is the patient and family education preparing for self-management. So how to administer an inhaler correctly. I can probably guarantee there's going to be a test question on that. And on 610, there is a 32-9. I would probably be safe to say that's probably going to either be a question on that from just that box or in combination with that one and 32-8. So definitely know those. And then the only thing that I have left is, let's see here, 587. I'm sorry I'm jumping all over the place. I just wanted to make sure you guys had all the boxes, and I made the PowerPoint first, and then I realized that I wanted to give you guys more of a heads up as far as what's important and what to know. Because I really do think that if you read the chapters, I mean truly read the chapters, and then listen to my PowerPoint, and then take all the little helpful hints and look at stuff, I think that you'll at least understand the concepts and get a better understanding of all the chapters without having to reread every page, because I don't want you to do that. It's a lot of time. But if you don't read the chapters first and you just listen to the PowerPoint, I think you're missing out on a lot of stuff. So let's see here, 557, 30. Oh, I'm sorry, 587. 587. I can't even count. So 587. 31-2, so it's communicating with a patient who is unable to speak. I think this is actually pretty important too, because and it's besides just being vented or unable to actually physically speak, but when your patients can't speak because it's hard for them to control their air, there's a lot of good things that are in here that you can actually do that I never really thought of before. I mean, people who are learn-oriented who can actually read and write, grab a piece of paper and a pencil. I mean, it's simple as that. So just kind of look over that. I think that's really pretty important. And then my last tidbit, which is really actually a big one because we talked about this in a meeting that I was in today, pages 566 and 567. All right, so table 30-1 is the comparison of low-flow oxygen delivery systems. You need to know and understand this box for several reasons. One, you're going to know this for the rest of your life as a nurse, but two, this is going to be a big, huge thing for Block 4, and for 3, there's going to be a test question on this because with nasal cannula, you can increase nasal cannula to a certain degree based on your patient needing more oxygen. So let's say you have a COPD patient, their SATs are around, let's say 85, 86. You can put them, as we know, COPD patients can only be on 2 liters, but you can gradually increase them a little bit just to get them better and be able to increase their oxygenation to at least the minimum, which is what, around 88, 89%. Because if that's baseline for them, then that's what they're living at. But if your patient is on nasal cannula, you can only titrate them up to 6 liters. After that, you have to be able to put them on a simple face mask and then actually put them up 6 liters and then 8 liters and then a partial rebreather after that from 6 to 11. So understand this box and the reason why you actually go from a nasal cannula to a mask, why you're doing it, and when the rationale is behind it, because I can tell you when you do your simulations from now until the day you graduate, or as you take care of patients from the time you graduate until the time you retire, you're going to be taking care of a lot of patients who are on these. And if you can't deliver the right amount of oxygen, then you're really just spinning your wheels, not getting them what they need. So you definitely need that. And then let's see here, 30-1, and then page 567, 30-2. Actually, it's 566, 30-1, and then 568, 30-2. And those are just more of the masks and stuff. So besides the boxes, but I think if you look at the pages, I think it's going to give you a lot of information. So you're definitely going to need to know these. So, all right, if you guys have any questions, let me know. I know that this was an hour and a half, so I know you're probably tired of listening to me. But like I said, I try to use the book along with my PowerPoint, and hope you enjoy the stories and all the little tidbits in the boxes. So let me know if you have any questions, and I will see you guys soon.